Hammer toe. A brief video. Definition. Hammer toe, flexion deformity at the proximal interphalangeal, PIP, joint and mild extension at the metatarsophalangeal, MTP, and hip joints. Hammer deformity characterized by PIP flexion, dip extension, MTP neutral, or extended. Deformity can be rigid or flexible. Epidemiology. Most common deformity of lesser toes. More common in older women. Second toes usually affected. Patho-anatomy. Overpull of extensor digitorum longus. Imbalance of intrinsics. Associated conditions. Painful corns at dorsal pip joint. Presentation. Symptoms. Pain on dorsal surface with shoe wear. Deformity. Physical exam. Flexion deformity of the pip joint of the lesser toes with extension of dip. Ankle plantar flexion. Flexible deformity corrects. Fixed deformity does not correct with ankle plantar flexion. Push-up test. Flexible deformity is reducible with dorsal directed pressure on the plantar aspect of the involved metatarsal. Effective over active extrinsics is removed. Imaging. Imaging not required in diagnosis and treatment. Treatment. Non-operative. Shoes with high toe boxes, foam or silicone gel sleeves. Indications. Pain and or corns on dorsal pip. Operative indications. 1. Deformity with associated pain. Surgery should not be performed for cosmetic purposes only. 2. Skin breakdown secondary to deformity. 3. Non-responsive to conservative measures such as wide toe box shoes and pads, toe crescents. Contraindications. Peripheral vascular disease. Special instruments, position, and anesthesia. 1. Patient position supine on standard operating room table. 2. This procedure can be done under local or regional anesthesia. 3. An ankle tourniquet, at 250 mm HE, is optional. 4. Number 15 blade. 5. Freer elevator. 6. Mearding retractors. 7. Double skin hooks. 8. Microsagittal saw blade. 9. 0.045, 0.054, and 0.062 inch smooth K-wire. 10. 3 to 0 viral sutures. 11. 4 to 0 nylon sutures. 12. 2.5 mm headless screw. 13. Plantar plate repair system, includes suture passers, joint distractor, and snap-off toom screws. Tips and pearls. A pulse oximeter placed on the toe is an excellent method of checking oxygen delivery to the foot. What to avoid? If toe circulation is compromised after K-wire instrumentation, it should be removed. If necessary, more of the proximal phalanx may be resected to relax the soft tissue envelope. Operative technique and approach. Prepare and drape the foot in the hospital's standard sterile fashion, ensuring adequate exposure available. If a tourniquet is to be utilized, the foot should be exsanguinated, and the ankle tourniquet inflated. Procedure. Flexible mallet toes. Make a percutaneous flexor digitorum longus tenotomy, through a transverse stab incision at the distal plantar flexion crease. Procedure. Rigid mallet toes, make an elliptical incision over the dip joint, see figure. Excise the skin, tendon, and capsule. Cut the collateral ligaments and remove the distal 3 mm of the head of the proximal phalanx and 1 to 2 mm of the base of the mid-phalanx with an oscillating saw, see figure. Place a smooth, 0.054 inch, K-wire across all 3 phalanges for approximately 3 to 4 weeks, see figure. Alternatively, a headless, variable pitch compression screw can be placed across only the dip joint, which is buried and left in place permanently. Flexible hammer toe. A Girdleston-Taylor flexor to extensor transfer with a dorsal capsular release is appropriate. If there is a fixed hammer toe deformity, this is treated by resection of the distal portion of the proximal phalanx, see below. The FDL tendon is harvested through a midline longitudinal plantar incision spanning the MTP and PIP flexion creases. The distal portion of the FDL is transected after being identified with blunt dissection. The 2 slips of the FDL tendon are split at their raphe. Tag each with a 2 to 0 non-absorbable suture. The slips of the FDL are passed subperiosteally around the proximal phalanx. They are brought out through a separate dorsal incision over the extensor mechanism centered over the proximal phalanx. With the ankle in neutral position, and the toe in 20 degrees of flexion, tie these onto each other and into the extensor hood. Apply a standard well-padded foot dressing. If used, remove the K-wires at 3 weeks for PIP and dip arthroplasty, and at 4 weeks when the MTP joint has been crossed. Ambulation should be in stiff-soled postoperative shoes. Thanks for watching this video. Do not forget to subscribe to my non-profit YouTube channel.